Enrico Camarda from
Yes.
Leuven is the next presenter. Enrico, as you saw, it goes by fast. So
okay, yeah.
Go for it. We are looking forward to hear about your paper.
Yes.
And I will not unmute myself so that you hear that. Yes.
Okay, thank you. So yeah, I'm Enrico Camarda. I'm a PhD candidate from KU Leuven. And I will be actually on the market in the next season. And today I want to talk to you about my paper, outcome-based prices in the English NHS. Of course, I would also be very happy to talk to any of you afterwards, poster, non-poster. So the price regulation and competition are policy tools that are commonly used in many healthcare markets. And recently there have been some studies that focus their attention on the effect of regulated prices on provider quality, but also on provider input choices. In this paper, what I do is I study the welfare impact of quality of outcome-based prices. And in particular, as policymakers are discussing their introduction, as more data becomes available about clinical outcomes of patients. But what is quality and what are these outcome-based prices? So quality is the clinical improvement after surgery. So in particular, I am using a measure from the English National Health Service that looks at the clinical improvement of patients that underwent hip replacement. And this measure actually controls for many patients' characteristics to make sure that this measure is comparable across different hospitals, even if hospitals have different types of patients. The setting is the English NHS, which is a prime example of managed competition in a healthcare setting where patients are free to choose where to go and receive treatment, face no co-payments, and cannot be rejected by the hospitals. Instead, hospitals receive the revenues from the state-funded NHS, and they do typically with a fixed amount of money, a regulated fixed price for each surgery that they perform. And this amount of money is typically uniform and does not vary with clinical outcomes. And this is true across many jurisdictions, not simply in England. In this paper, I actually studied then the impact of prices that instead would vary with the clinical outcomes. In particular, it would be higher or lower for a certain threshold of quality. So for example, if prices would be 10% higher than a baseline price, if quality is 1 standard deviation above the national average, at least 1 standard deviation above. So what I do in my paper, I study the welfare effect of these prices. And first I look at the evidence from a pilot reform. And then I develop a partial equilibrium model of demand and supply of this market and perform counterfactuals that actually go to change the uniform prices and introduce these outcome-based prices. So basically I change in the first order condition of the hospitals, this fixed price part. In my model, I do have demand, and for the moment I'm following Berry 94 to estimate the preference of consumers that trade off between quality and waiting time in their local market. Then I have a cost function that corresponds to a production function where a hospital pick their inputs to provide a certain level of quality and perform a certain number of surgeries, given their own productivity, but also given the quality of their competitors, because hospitals here are competing nationally in quality. And one note, hospitals can modify their quality and quantity only by picking different levels and quality of inputs. So this is the way in which they can change their quality and quantity. I estimate this cost function using an Ariane bond rho differencing to basically control for productivity and also measurement error. Interestingly, I can also back out non-profit motives of the hospitals. Given that I have estimated the marginal cost separately. Then from the first order condition of the firm, of the hospitals, I can back out the marginal non-profit motives as the difference of the marginal revenue, partially from demand estimation from data, and my marginal costs. Then I specify also social welfare function, for which I need the cost of public funds and the value of externalities for these surgeries, and I get the value for them from other studies on this market. So then, with all this machinery, I can perform different counterfactuals with quality-based prices and uniform prices. And what I find is that rewards for quality increase welfare, especially if the best hospitals are the most productive hospitals. And this happens to 3 channels. So there is a direct effect where the additional government expenditure is given to a small subset of hospitals, which are the best hospitals, but also the most productive and can provide more quality relatively more cheaply. Then there is a competition effect. So where even given the quality is a strategic complement, even hospitals that are not rewarded and are in the same market as the rewarded hospitals are going to increase their quality as a response, even if they're not receiving this additional government money. And then finally, there is a measurement error effect. So quality is measured by the regulator, which is giving out the rewards with a measurement error. This means that even hospitals that are below the threshold have a positive probability of receiving a reward and will increase their quality, even if at the end, some of the hospitals that have increased quality will not receive this additional money. So all these effects together actually lead to a reallocation of patients and resources to the most productive hospitals, but also to an increase in competition. What instead happens with the punishments is a bit different. Punishments instead are decreased quality and are welfare detrimental. And this happens because these 3 channels actually do not work all in the same directions as in the case of rewards. So the first effect is still positive on welfare. And there is a government saving because it's spending less money, government is spending less money for the worst hospitals. And these hospitals are the least productive. So for them, it's actually too expensive to provide quality above the punishment threshold and will decrease quality and receive less patients, which can be a good thing. However, the competition and the measurement error effect compensate for this effect and lead to other hospitals that are not punished and for which there is no saving to actually decrease their quality as well. And this is welfare detrimental, and the net effect is welfare detrimental. So then I find also that the rewards are better than uniform prices if there is a positive correlation between productivity and other characteristics of the hospitals that are appealing to consumers. So I don't have time here to explain like the details of why this is happening, but when this is happening, then the most productive hospitals are actually also the best hospitals. Here I have a table with my main results.
Yeah.
And
2 minutes, Enrico.
From the main results, you can see that, so from the baseline, I have like a welfare loss of around 5%. And then with higher uniform prices, there is a small positive effect on welfare, while with rewards, there is a larger positive effect on welfare. Instead, as I said, with punishment, there is this negative effect on welfare. In terms of contribution, so I have 2 contributions. The main one is that I studied the effect of this quality, the welfare effect of these quality-based prices. But then I also have a minor methodological contribution in that I separately estimate this cost of quality of outcomes from productivity. To the best of my knowledge, there is only one paper that estimated production function in a healthcare setting, using the tools of the productivity literature. And I also do the same, but I do it on a cost function and considering in a more complex environment where quality is not simply related to infection, but something a little bit more complicated, but also I address the problems of serially correlated measurement error and input price differences. This is important because typically in healthcare, we think about quality in many cases as number of doctors per patient or number of nurses per patient. However, this measure can also be seen as a measure of productivity. And in this paper, I try to distinguish the two, especially as it is important for me to understand which are the hospitals that are producing higher quality. And so, yeah, that's, I think I was kind of on time, and I'm really happy to talk to any of you about more details about this paper, and I see you in the poster session. Thanks, thank you very much for the opportunity to present.